I am really pleased to introduce our next speaker. Is Dr. William Morice. Bill received his MD PhD from Mayo. He trained in hematopathology with Kurt and me, and was really a star all throughout his fellowship and through his early part of his consultant career, where he became an expert in flow cytometry. He was the director of our flow cytometry laboratory, particularly in disorders of natural killer and cytolytic T lymphocytes, and more recently in the area of multiple myeloma and plasma cell dyscrasias. Now, of course, Bill was becoming a little bit too productive, and so we had to make him division chair so that he'd have some administrative responsibilities to slow him down. But that doesn't seem to have slowed him down very much because he's continued to do great studies on flow cytometry and test utilization in the context of plasma cell dyscrasias, and that's exactly what he's going to talk to you about today. So, Bill, the podium's yours.
Well, thanks, Paul, for that kind introduction. So now, if it could, if I do poorly, it'll be a completely public flame out. So that'll be awesome for all of us. So, all right. So for today, in the amount of time that we have, I think what I'd really like to accomplish is, number one, just sort of describe the landscape of plasma cell proliferative diseases. What are we dealing with here? Describe what the role of the laboratory is then in that context in terms of establishing the diagnosis. And then, as with the other disorders you heard about, not only establishing the diagnosis, but what is the role of the laboratory in really guiding therapy, monitoring response to therapy, and also detecting disease relapse. All right. So plasma cell proliferative disorders, as a whole, they're actually clinically a very heterogeneous group of conditions that all have as a common feature the presence of clonal or monotypic plasma cells. These diseases are then categorized and subclassified based on both clinical and laboratory as well as radiologic features. And again, it really includes a host of diseases. What we're going to focus on for the purpose of this talk are monoclonal gammopathy of uncertain significance, smoldering myeloma, and multiple myeloma. So what are the disease definitions then for at least these three? Well, smoldering myeloma and multiple myeloma are plasma cell proliferative disorders that are really defined either by end organ damage or by having a high plasma cell burden or a high disease burden. So that disease burden can be manifest by a high serum monoclonal protein level or by a high proportion of abnormal plasma cells in the bone marrow. Now, if you have either of these, but you have no end organ damage, from the plasma cells themselves, this is termed smoldering myeloma. In converse, if you have end organ damage, even in the absence of a high plasma cell burden that's determined by bone marrow examination, you are by definition dealing with multiple myeloma. What are the clinical manifestations of end organ damage? The acronym is CRAB, standing for hypercalcemia, renal insufficiency, anemia, and bone disease, and that's what the radiograph here is showing you, the moth-eaten appearance of the calvarium due to involvement by multiple myeloma. So if that's multiple myeloma and smoldering myeloma, then what is MUGUS, or monoclonal gammopathy of uncertain significance? Well, this is, again, a plasma cell proliferative disease, but in this context, or in this instance, it's now defined by a low burden, as it's shown by either a low serum monoclonal protein and fewer than 10% monoclonal plasma cells in the bone marrow, and also there can be no end organ manifestations of the disease itself. As defined in this way, this is really a very clinically indolent disease with about a 1% per year progression rate to full-blown clinically evident disease, most typically multiple myeloma. Amyloid can develop, and in the case of IgM MUGUS, which is probably a disease entity which will be redefined over time, developing into lymphoma or lymphoproliferative disease. So if that's what we're talking about, then how common are these in kind of the whole, if you look into the grab bag of plasma cell proliferative diseases, what are you most likely to grab out? Well, the reality is that in looking at the 40 or almost 50-year experience of Mayo Clinic, the majority of cases of plasma cell proliferative disorders are MUGUSes and will remain MUGUSes for the entirety of their clinical course. Next most common is multiple myeloma. As you can see, smoldering myeloma here is actually a pretty small slice of the pie. And then amyloid, actually a pretty significant slice of that pie, but that will be discussed by Dr. Curtin in the next talk. So MUGUS and smoldering myeloma, both subclinical diseases. So how do they relate to each other? Well, as I mentioned before, for MUGUS, it's actually relatively common, particularly as patients age. Up to 3% of patients over 70 will have this condition. Again, it has a very slow rate of disease progression, shown here in the red line. About 1% per year will progress. If you look at smoldering myeloma in contrast, which is on the blue line, you can see there's a much higher rate of disease progression. But if you really break down this curve, you can see that the majority of patients with smoldering myeloma who progress actually progress within the first 5 years of the diagnosis. And after that, the curve really starts to flatten out such that it starts to look a lot like the progression curve for MUGUS. So then what are some predictors of whether a patient with smoldering myeloma is going to progress to multiple myeloma? A high M spike, a high plasma cell burden, both will be predictors of early disease progression, as well as a markedly abnormal free light chain ratio, the presence of circulating clonal plasma cells, which we'll discuss more later, and also IgA isotype MUGUS or smoldering myelomas tend to have a more rapid rate of progression. But again, this is really within the first 5 years. The thought is now that it might actually be what we call smoldering myeloma as a clinical or clinical pathologic entity might actually be two diseases, some MUGUSes with relatively high plasma cell burden, and others that are actually early multiple myeloma, just diagnosed pre-end organ damage. So how do we differentiate these? This is something that our clinicians have been very interested in, and hematology researchers. Basically, the one thing we know for sure is that patients with very high plasma cell burden, so greater than 60% plasma cells, uncommon in this group, but when it occurs, almost all of those patients will progress to multiple myeloma within the first year. And so this really is, if you have a very high plasma cell burden, it probably is multiple myeloma, and best to call it that because the patients will need treatment. So the other then question that comes up is, what is the relationship of multiple myeloma to MUGUS? Some patients, does every multiple myeloma have an antecedent MUGUS? This was addressed in a very large trial, which was published a few years ago. Over 70,000 patients enrolled. Of those, 71 or 0.1% or so developed multiple myeloma. And basically, if you looked back, all of them had its antecedent serum studies, and all of them had an antecedent MUGUS. So MUGUS is the precursor lesion for multiple myeloma unequivocally. That being said, and one of the things that really, if there's one thing that you remember that from this talk, however, is that all the things that we're going to talk about as being important for prognostication and biomarkers for disease aggressive and multiple myeloma, they don't help in telling you if whether a MUGUS patient is going to progress to multiple myeloma or not. And that's, I think, one common misconception that people have. So those are the diseases we're trying to help the clinicians to diagnose. So the question is, what is my job as a hematopathologist in terms of assisting in that process? Well, the laboratory really has two primary functions. One is to establish plasma cell clonality, and the other clearly is to help to assess the disease burden. There's a lot of things that happen before bone marrow is performed in terms of serum studies. Really, for the purpose of this talk, it's more hematopathology focused, so we'll really focus more on the bone marrow manifestations and some peripheral blood flow studies. So, and then in cases where the disease burden is high enough to define multiple myeloma, or I thought I was waiting for the shepherd's hook there for a second, but it's like the Gong Show. The last two are going to be Gong Show. Like no, in case of multiple myeloma, is actually to determine risk, guide therapy, assess response, and to detect relapse. But again, this is only patients that actually require treatment for their disease. So a little bit about immunophenotyping. The flow cytometry world is trying to converge around this issue. Really, there's two ways that one can assess myelomatous or abnormal plasma cells by flow cytometry in terms of determining clonality. One is to look for immunoglobulin light chain restriction. One is to look for, if I can get this to go back. There we go. Immunoglobulin light chain restriction. Again, early on, like when I first started around 2000, we paid a lot of attention to kappa lambda ratio. The reality is if you do a good enough job with flow cytometry, you should be able to isolate the plasma cells so that the ratio becomes less important. But again, this can be performed by either flow or immunohistochemistry. The other methodology really focuses on antigen expression and is sort of simplified in this dichotomous diagram, which is from the Spanish group. It's a few years old now, in which normal plasma cells tend to be CD19 and CD45 positive and CD56 negative, and abnormal or myelomatous plasma cells tend to have the converse phenotype. So there's basically, these are two schools of thought, or had been two schools of thought of how to detect abnormal plasma cells by flow. there's a real push now nationally and internationally to kind of standardize how we do plasma cell flow cytometry, and most methods, actually now are a blend or a hybrid of both approaches. So what do we do at Mayo Clinic? Well, we have a method which we introduced a couple of years ago, which is an 8-color flow cytometry method, which combines basically light chain expression, surface antigen immunophenotyping, and DNA content analysis with high event collection to simultaneously assess for basically plasma cell clonality through light chain restriction and phenotype, and plasma cell DNA content, and importantly also to estimate the number of normal or non-malignant plasma cells, at least in their relative proportion to the abnormal plasma cells, because it looks like this is also an important biomarker for these patients. So a simplified schematic. I'm not going to get all flow geeky on you guys. So if you guys want to nerd out on flow cytometry, we can nerd out together after the talk. But basically, that's my niece was just visiting Mayo Clinic, and she's like, wow, it's like a camp for nerds. And I'm like, yeah, it's something like that. Thanks. Awesome. Just what I wanted to hear. So here's how we do flow at the camp for nerds. Basically, we do surface phenotyping to isolate the plasma cells in total. And then what we do is actually, by that phenotyping differences, actually discriminate the abnormal and the normal plasma cells. So you can see here are the normal plasma cells that are CD45 positive. CD19 you can't see is on this y-axis. These cells are at CD19 positive, and they're showing polytypic light chain expression with subsets positive for kappa and lambda. In contrast, here are the abnormal plasma cells. They're admixed. They have the same surface density of CD38 and 138, but they actually lack CD45 expression. And here you can see that they're light chain restricted and CD19 negative. Oop. There we go. And so what we did is we actually compared this to just a 6-color method that used slightly less event collection and less phenotypic interrogation of the plasma cells. And what we found is that this method is indeed much more sensitive. So we had about 8% of cases that were missed by a 6-color Canto method that were picked up with this higher sensitivity methodology. And again, these were almost all cases that had very low plasma cell burden. With the sensitivity of this method, sensitivity is about 1 in 10,000 at least of our current method. So what do you need to do? What does any laboratory need to do in terms of analyzing myeloma cases or potential myeloma cases? Well, again, in terms of prognostication for patients that have myeloma and require treatment, I think plasma cell proliferation, this has been the mainstay of prognostication of myeloma patients at Mayo for many, many years. It can be performed in a variety of ways, either by flow cytometry, which is the way that we do it now, and the way it's been done in Spain and Salamanca for a number of years. The old methodology was a slide-based immunofluorescence assay, which we managed to actually outdate and discontinue using the flow cytometry. And again, that's one of the things I think we have to be cognizant of. One of the utilization issues that we don't talk about is, with the advent of new methodologies, what can we stop doing in the laboratory? And this was actually very labor-intensive and costly. So we're able to stop doing that. You really need to assess the plasma cell DNA content, or ploidy. This can be done by a variety of methods. Initially, it was primarily metaphase analysis. A lot of labs still doing this. You can also do this by flow cytometry, as I'll show you, and also by FISH studies. And really, I think what we're finding is that the metaphase study, I'm not going to show a lot of data to this today, but unless you're worried about a myeloid neoplasm occurring in the background of a plasma cell disease, probably no role for conventional cytogenetics in the evaluation of multiple myeloma patients. Reciprocal translocations are important, as I'll show you. These can be, right now, the state of the art is to do FISH testing. There are some other methodologies with the advent of next-gen sequencing technologies which are out there. And there are a host of other assays which can be performed for prognostication, including gene expression profiling and gene mutational analysis. These are included. We do not routinely perform these on patients at Mayo Clinic. The Arkansas group and Dr. Barloghi very heavily pushes gene expression profiling, and I do think this might be an issue that the myeloma community is going to have to address collectively, is how many prognostic markers are enough, and how many do you really need? So just to show you how we estimate DNA content by flow cytometry using our flow method, here we've now isolated, actually, this is simplified, but we separately isolate those normal and abnormal plasma cells, and then we collectively analyze their DNA content. So here's CD19 on the x-axis, and DNA content is measured by DAPI staining on the y-axis. What you can see here are the CD19 positive plasma cells actually have diploid DNA content, And here are the abnormal plasma cells. In this case, they're kappa light chain restricted. They're CD19 negative, and you can see that they have higher fluorescence on the y-axis, meaning that they're hyperdiploid. So we can actually assess DNA content by flow cytometry in these patients. The other thing that we do simultaneously is we basically construct a cell cycle curve using DAPI staining and estimate the number of cells in G0, G1, G2M, and then cells in S phase is what we report by estimating two. You can also report proliferation fraction, which is basically everything that's not G0, G1. So one of the questions for us, we do a lot of FISH testing right now to look at DNA content as well as conventional metaphase analysis. This is data from the validation of the assay, which is a couple years old. We have a much larger data set which basically validates these findings. What we found essentially is that the flow method is much more sensitive for picking up abnormalities in DNA content than either FISH studies or conventional metaphase analysis for the most part. And this, again, of these cases there were 17 cases in our validation set that had normal cytogenetics but were clearly aneuploid by flow cytometry. Almost all of those had low plasma cell burden. The other cases, group that we tended to pick out were those that were hypodiploid, maybe a little bit more sensitive. So some conclusions just in terms of, for us, this gets back to the old issue of what do we really need to be doing in these patients? What can we discontinue doing for cost saving, for improving care? In our own practice, at least, we found that really DNA ploidy by flow appears to be equally sensitive to cytogenetic studies for detecting abnormalities in DNA content in plasma cells. There are a few cases that are abnormal by one method and not the other. There are some cases that were abnormal by conventional metaphase or by FISH, really by FISH, that were normal by flow, but these are very small, kind of at the ends of the bell curve. And really, overall, it seems to be very helpful when the percentage of abnormal plasma cells is low. And also, one of the interesting things here, which I haven't discussed, is that you can actually pick up multiple aneuploid cases, individual cases where there's multiple DNA contents within the same clone, which really it seems to be strongly correlated with either disease progression or clinically aggressive disease. And the last but not least, I've not shown on here, is actually it helps with the sensitivity of the assay as well. So how do we use all of these things at Mayo Clinic? The question that came up before is that the expense isn't in the lab, it's in the drugs. Now, there's not a uniform approach. Mayo is a little bit different. Perhaps not everyone adheres to this philosophy of myeloma treatment, but basically what we do at Mayo is that we look at reciprocal translocations, look at proliferation, look at DNA content, and basically assign patients to either high risk or intermediate or standard risk categories. Again, unfortunately, one of the things for us is that our ability to generate data is outpacing our ability to understand exactly what it means for prognostication. So we do have some here now. For instance, we really need to kind of revalidate what proliferation means. Clearly, there are some that are probably high risk by proliferation. But basically, once we assign these to a category, we then guide treatment. But remember, all this is only needed if CRAB is present or if the patients have greater than 60% plasma cells. If they don't have symptomatic myeloma, or they don't have greater than 60% plasma cells in their marrow, they don't need any of this. And so what we do, though, is that patients at Mayo that are into the high-risk category basically get started on bortezomib-containing regimens, where those that do not, we actually save the bortezomib and save them the cost of bortezomib and start them on Revlimid only or Revdex basically based regimens. So that's basically used for treatment stratification, either the triple therapy or just Revlimid therapy. So what's the role then of screening studies? This has come up. Again, we get a lot of patients coming through that haven't been previously treated for myeloma and not prognosticated, or we don't know the clinical history. So the question comes up is, what do you do in a reference laboratory setting, in particular when you get cases with low numbers of abnormal plasma cells? We have been going back and looking at our data, and what we have found is that, because this happens so frequently, actually we have a pretty costly process in the FISH lab, where we have FISH studies ordered for myeloma, where we have to actually hunt and peck for the abnormal plasma cells by using cytoplasmic immunoglobulin staining or other methodologies, cell purification, to try and find these cells, because we just don't know if it's really needed or not. And what we found basically is that when you use a highly sensitive flow method like ours, that's not the only way to do it, but if you're at 1 in 10,000 or so, basically if you have fewer than 0.5% monotypic plasma cells, or you have no monotypic plasma cells, you can basically cancel all the expensive cytogenetic studies because they're just basically non-informative. A few other things that are out there that are, before we add more, before we spend more in terms of understanding the risk for these patients, what do we know already? And one of the things that we do know, for instance, is that in patients with newly diagnosed myeloma, actually the plasma cell compartment itself, which we can now decipher by flow cytometry, tells us a lot about how the patients are going to behave. So this is from the Spanish group again, where they quantified or stratified patients into those that had greater or lesser than 5% normal plasma cells as part of the total plasma cell pool at the diagnosis of multiple myeloma. And what they found is basically if you have more than 5% normal plasma cells, which are the blue curves here, they had much statistically significant lower rates of disease progression and also better overall survival. The other thing which we use at Mayo is it's still a 6-color approach, but it's actually peripheral blood flow cytometry, which is not a diagnostic test, but is a prognostic test for the detection of abnormal circulating plasma cells. So you can see here again, we've detected abnormal clonal plasma cells that are CD19 and CD45 negative, kappa light chain restricted, and actually in this case have some differences in CD38 and CD138 expression. There are actually normal plasma cells present as well. And what we found basically was we went through and stratified, looked at 157 newly diagnosed multiple myeloma patients, and found that if they had more than 400 of these circulating abnormal plasma cells out of 150,000 events collected, at 23 months follow-up, this is actual survival data, and actually one of the more strongest predictors for overall survival. So if you had fewer than, don't have a lot of circulating plasma cells, survive well. More than 400, median survival is much worse. So that's really at diagnosis. So then in terms of after the diagnosis is made and the patients are being treated, the real role of laboratory is to identify disease relapse and help guide treatment there as well. Again, there's a lot of different ways you can do this. In terms of detecting the abnormal plasma cells, there are groups that are looking at next-gen sequencing of immunoglobulin gene rearrangements. There's probably a lot of interclonal diversity, so it appears that flow is probably going to be the method of choice, and there are efforts underway to try and standardize this internationally. It's important to note that repeat of the entire risk stratification is not required at relapse, but there are some studies which can be predictive in terms of how the patients are going to do. So one of the things is, what's the value of doing flow cytometry and looking for MRD? This is very similar to Dr. Curtin's studies with CLL, or the data he showed with CLL. This is again from the Spanish group, but we have similar data from our own practice now with high sensitivity flow. Basically, MRD negative patients, which are in blue, have much lower rate of disease progression and relapse and much better survival than those that are MRD positive 100 days after allogeneic stem cell transplant, and this is held for a variety of therapies. We also did the same thing to look at actively relapsing myeloma patients and what was their value in doing peripheral blood flow cytometry to detect the abnormal clone. So we had 145 patients. We did statistical analysis and found that we could stratify patients, in this case, with a lower burden of greater or less than 100 abnormal plasma cells per 150,000 in the peripheral blood. Again, median follow-up of about 22 years, and this is really, again, very powerful in terms of how patients are going to do. So if they do have, it probably has to do with the ability of the plasma cells to escape the bone marrow microenvironment and become independent of the bone marrow microenvironment for their survival. But this is really a very powerful predictor of how patients will do. So, kind of to close, now I didn't realize that we were in an algorithm beauty contest, so we'll have to see mine. This is now, I don't know, I was thinking, I don't think I'm the Dixie Cup lady from New York that got a lot of grief when she won Miss America. Anyways, so as an entry point, when you have a bone marrow in a patient with a suspected plasma cell proliferative disease, high sensitivity flow cytometry is probably the place to start. At least it is in our practice. If there's no clonal plasma cells, you can stop. If there are clonal plasma cells, but there's no CRAB and there's not a high disease burden, you can stop. You can just call it a plasma cell proliferative disease. If there's clonal plasma cells, and notice mine's multicolored build sequentially. Should have had a soundtrack, then I would have won for sure. Anyways, if there are clonal plasma cells, and the patient, it's a first-time diagnosis of myeloma, either because of a high burden or because of CRAB, then they need all of the prognostic studies, at least proliferation, ploidy analysis, DNA translocation analysis. I would argue probably peripheral blood flow cytometry diagnosis is helpful. And also, again, potentially gene expression profiling. And then in relapse patients, basically, there are some fish studies that are associated with disease progression and poor prognosis, and again, peripheral blood flow, but a much more limited set of analyses. So some closing considerations then. Again, the ideally to use high-resolution bone marrow flow cytometry. It's great if it quantifies DNA content and proliferation. I don't think that is really as necessary as just the fact that it really should be highly sensitive. You can use FISH to assess ploidy. It is true that as the plasma cells age, so from a reference lab perspective, they can become harder to detect. Again, remember, though, that in most cases where you're going to need a lot of the ancillary studies, the plasma cell burden should be high, so that really should not be a barrier. But still, you can assess, use FISH to identify abnormalities in DNA content as well as reciprocal translocation. Again, probably not a role for metaphase analysis unless you're worried about MDS. Semi-quantitative flow for circulating plasma cells actually can be a very powerful prognosticator in these patients. And I think we really have to be careful in evaluating the role for more expensive technologies and providing prognostic information in these patients to see if it's really of any added value in terms of what we can already do. And with that, a couple minutes ahead of schedule, so I'll close. Thank you. Go to the next talk and just do questions at the end.
Questions?
Oh.
Yeah, my question is, some monoclonal gammopathies are associated with tissue injuries or some of the benign ones, and I was just wondering if you could comment on what you would consider appropriate workup for people who had monoclonal gammopathies with, renal significance or neuropathies and so forth, where it doesn't meet the criteria of myeloma but has tissue injury. Do you think that those require fuller workups?
To be honest with you, I think that kind of probably fits better into what Dr. Curtin's going to speak to next. I think outside in the bone marrow, they're really, I would say not. I mean, I think if those studies really end up being more serologic and clinically correlative, as opposed to there's not a whole lot of bone marrow studies that we're doing. We are looking at some things for renal injury right now to see if there's anything in what we're doing that can predict for whether there's renal injury. But as far as I'm aware, at least in our studies, we don't do anything additional.
No, my question is in identifying what the disease is, when you're looking at prognostic markers, if you identify a plasma cell population that looks benign in the bone marrow but is causing tissue injury, would you do the cytogenetics and some of the other things as part of the workup to identify treatment options?
Yeah, if it's amyloid, the answer is no. And honestly, I know Nelson Lung at our institution is interested in looking at some of these things, but as far as I'm aware, there's nothing that we can do in the laboratory to help prognosticate in those instances. Great. Thank you all for your attention. Appreciate it.